Good afternoon, everyone. So my next video is on the topic macrolides, which are other protein synthesis inhibitors. And before I start my video, I want to request you that if you like this video and if it is useful and helpful to you, kindly subscribe to my YouTube channel, that is Dr. Nitika Han's Pharmacology Discussion. So now I'm going to start with macrolides, which are the protein synthesis inhibitors. Now the chemical structure of macrolides is this: like they have a macrocyclic lectron ring, and which are attached to deoxyribose sugars, and they are attached, and they have a macrocyclic lectron ring in their structure. This is the structure of macrolides. Macrolides can be classified, or the names of macrolides are erythromycin. These are thromycins, and these can be erythromycin, roxithromycin, clarithromycin, azithromycin, paramycin. These are the various macrolides which I'm going to discuss with you in this video. Now, erythromycin, first of all, it is obtained from Streptomyces erythraeus. And at the low concentration, it is bacteriostatic, and at the high concentration, it is bactericidal. Mechanism of action is that it binds to the 50S ribosomal subunit, interferes with translocation. How? Because from the A site, there is no translocation of the amino acid chain from the A site to the P site. So amino acid acceptor site does not get freed for the new amino acid to attached by the brought by the tRNA. So from the A site to P site, translocation does not take place. So that inhibits the protein synthesis. This is the structure of mRNA, how tRNA attaches to the A site. This is growing peptide chain over the A site, and how translocation takes place between the A site to the P site, from the A site to the P site. And this translocation is inhibited by the macrolides group of the drugs. The macrolides bind reversibly to the 50S subunit of the bacterial ribosomes. There is evidence that some prevent the transfer of peptidal tRNA from the A site to the P site, thus preventing the elongation of the polypeptide chain. Means polypeptide chain will not be elongated, because from the A site to P site, the translocation doesn't take place, and so protein synthesis is inhibited, and thus it is antibiotic in nature. Now, protein synthesis inhibitors at 50S ribosomal subunits can be macrolides, ketolides, which is telithromycin and cethromycin, lincosamide like clindamycin, lincomycin, streptogramins like vincristine and delphopristine, oxazolidine denones are linezolid, dedazolid, tedazolid, torazolid. These are all protein synthesis inhibitors, and in this video, I'm going to discuss with you macrolides. Spectrum of activity of macrolides are that these are effective against mostly gram-positive bacteria, that is gram-positive cocci and gram-positive bacilli, and some of the gram-negative bacteria also. These are second-line drug of choice to the penicillins. And these are used when the patient is allergic to penicillins. Then we use these macrolides. These can be effective against Streptococcus pyogenes, Streptococcus pneumoniae, Neisseria gonorrhoeae, Corynebacterium diphtheria, Mycoplasma pneumoniae, and Gardnerella vaginalis. And the uses is by the clap, by the mnemonic clap for chancroid, A for atypical, L for Legionella, A for atypical pneumonia, and P for pertussis or whooping cough. And other uses can be diphtheria, toxoplasmosis, mycobacterium, avium complex infections. And these are also effective against other gram-positive bacteria causing infections like syphilis, tetanus, streptococcus, pharyngitis. Resistance, all cocci develop resistance mostly by acquiring capacity to pump it out. Means there are efflux pumps are available, which pump the macrolide out of the cell away from the ribosome, and they have a low level of resistance to macrolides. They confer low level resistance to macrolides, and they influx the macrolides from the inside of the bacteria to the outside by the active reflux, and it accounts for 80%. Altered target sites are that they alter the macrolide binding site on the ribosome. So the gene is encoded, and the macrolide binding site on the ribosome is altered, so that can confer high level resistance, that is altered target sites. Most of the resistance are plasmid mediated, and there is also cross resistance. Means if the patient is becomes resistant to one macrolide, there is resistance to other macrolides also. Pharmacokinetics is these are easily destroyed by the acid in the stomach. So these are acid labile. They are well absorbed orally. Food delays the absorption, well distributed, and they cross the placenta also. They doesn't cross the blood-brain barrier, erythromycin, and it's excreted in bile, and half-life is just 1.5 hours. And it is available in these formulations like estolate, sodium succinate, gluceptate, lactobionate, and stearate. These are the preparations of erythromycin. And adverse effects are known from the mnemonic macro. M is for the motility receptor stimulation, which leads to diarrhea, nausea, vomiting. So it can be used in the treatment of diabetic gastroparesis and paralytic ileus because it is known to cause diarrhea in the patients. A for allergy, that is hypersensitivity. C for cholestatic jaundice, which is mostly seen with erythromycin estolate, and it is it is contraindicated in the pregnancy because it causes the cholestatic jaundice in the mother when it is given to the mother in the pregnancy. And otherwise, the macrolides, these are safer drugs to be used in pregnancy along with penicillins and clindamycin, PCM. And Rho is for the reversible autotoxicity. It is known to cause reversible autotoxicity. And other drugs like vancomycin, aminoglycosides, and cisplatin, they are also known to cause autotoxicity, but that is irreversible. These are known to cause irreversible autotoxicity, erythromycin, and it also causes hepatitis. Interactions are potent inhibitor of hepatic microsomal cytochrome P2A4 and cytochrome PA1A2 inhibitors. So levels of theophylline, carbamazepine, valproate, ergotamine, and warfarin will rise in the body, leading to various side effects. Terfenadine, estomazole, and cisapride, which are antihistaminics and prokinetics, these cause the QT prolongation and ventricular arrhythmias when the levels of these drugs increase in the body, because the cardiovascular side effects and the serious side effects, serious death can occur. They reduce the plasma clearance of ketoconazole, theophylline, carbamazepine, cyclosporin, digoxin, warfarin, and diazopyramide. And these drugs compete for the same binding site. Means they also act at the 50S ribosome and they prevent the translocation. That is chloramphenicol and clindamycin. Physical and chemical incompatibility between parental forms of erythromycin. There is physical and chemical incompatibility, and it is incompatible with vitamin B complex, ascorbic acid, which is vitamin C, tetracycline, colistin, chloramphenicol, heparin, and phenytoin. Limitations of the erythromycin is that it is narrow spectrum. It has the narrow spectrum of activity. Gastric intolerance because it causes nausea, diarrhea, vomiting. It is gastric acid labile. It has low oral bioavailability, and it has poor tissue penetration. It has a short half-life. Newer macrolides are roxithromycin, clarithromycin, azithromycin, and spiramycin, which I'm going to discuss with you. First of all, roxithromycin, it is the longer acting, semi-synthetic, acid stable, and antimicrobial spectrum is just like erythromycin, and is more potent against Moraxella, Catarrhalis, Cardinella, Vaginalis, Legionella, and less potent against Bacillus pertussis. Pharmacokinetics is it has the good antral absorption. Good oral absorption is there. Half-life is 12 hours, so twice daily dosing can be given, and it has better gastric tolerability, and it has the cytochrome P450 affinity is lower than the erythromycin, so drug interactions will be lower. Dose is 150 to 150 milligram BD because the half-life is 12 hours, so BD dose is given. Alternative to the erythromycin for respiratory, ENT, skin and soft tissue infections and genital tract infections with similar efficacy. This is an alternative to these infections like respiratory, ENT, skin infections, soft tissue infections, genital tract infections. Side effects are same like diarrhea, nausea, abdominal pain, vomiting. It also causes headache, vertigo, rashes, abnormal liver function values, and alteration in senses of smell and taste. Clarithromycin, it is effective against Mycobacterium avium complex and Mycobacterium leprae and other anaerobes. So it is more active against Helicobacter pylori, Moraxella, Legionella, Mycoplasma pneumoniae, and sensitive strains of gram-positive bacteria. Means it is effective against gram-positive bacteria and anaerobes, and we have Mycobacterium avium complex and Mycobacterium leprae, and Helicobacter pylori and Moraxella. Clarithromycin pharmacokinetics it is stable and it is rapidly absorbed. Oral bioavailability is 50% due to first pass metabolism, food delays absorption. Oral bioavailability is 50% and due to first pass metabolism, and food delays is absorption of clarithromycin. It has a larger tissue distribution. It is metabolized by saturation kinetics. Plasma half-life is more 3 to 6 hours at lower doses and 6 to 9 hours at high doses. No dose modification is needed in case of liver disease or renal failure. It can be used in upper and lower respiratory tract infections, otitis media, whooping cough, atypical pneumonia, skin soft tissue infection, and it is used in the triple drug regimen for the H. pylori associated peptic ulcer. CAP regimen, this is clarithromycin, amoxicillin, and omeprazole, which is the proton pump inhibitor, can be used to treat H. pylori associated peptic ulcer. It is the first line drug in the Mycobacterium avium complex infection in AIDS, and it is also used in the treatment of tuberculosis and leprosy and atypical Mycobacterium diseases. Dose is 250 milligram BD for 7 days. In severe cases, 500 milligram up to 14 days. Gastric side effects can be there, and high doses can cause reversible ototoxicity. Clarithromycin is known to cause pseudomembranous enterocolitis, hepatic dysfunction, and rhabdomyolysis. Its safety in pregnancy and lactation is not known. It inhibits the cytochrome 3A4, and drug interaction potential is just similar to erythromycin. It's just the cytochrome P3A4 inhibitor. So various drug interactions can occur with clarithromycin. Azithromycin, it is the azalite congener of erythromycin, expanded spectrum of activity, and has the improved pharmacokinetics and better tolerability and better drug interaction profile. Means it does not inhibit the cytochrome P3A4 and 1A2. So drug interactions are not seen with azithromycin, plus it is longer acting, so it can be used once daily. It has the better tolerability and improved pharmacokinetics. It's more effective against Haemophilus influenzae, but less active against the gram-positive cocci. It can be effective against Mycoplasma, Chlamydia, Legionella, and Moraxella. And it is not effective against erythromycin-resistant bacteria. Penicillin is producing Staph aureus are inhibited, but not the methicillin-resistant Staph aureus. Good activity is noted against Mycobacterium avium complex. Pharmacokinetics, it is ACE stable, it has the rapid oral absorption, it has marked tissue distribution, intracellular penetration is seen in various cells, and it has higher concentration in macrophages and fibroblast. Its half-life is more than 50 hours, once daily dosing is effective, and it has the higher efficacy, better gastric tolerance. First-line drug for Legionella pneumonia, Chlamydia trachomatis, and duodenomyosis caused by Clamobacterium granulomatous, chancroid, and penicillinase producing Neisseria gonorrhoeae urethritis. This is first drug for the CLAP, that is the chancroid, atypical pneumonia, Legionella pneumonia, pertussis, and atypical pneumonia and Legionella, and penicillinase producing Neisseria gonorrhoeae urethritis. These are the other indications. It can be used in the skin and soft tissue infections and in various oral respiratory infections, lower and upper UTIs conditions, and in In the respiratory infections like pharyngitis, tonsillitis, synovitis, otitis, in ear infections like otitis media, pneumonias, chronic bronchitis, and it is also effective against Mycobacterium avium complex in AIDS patient, in MDR typhoid fever, and in toxoplasmosis. Dose is 500 milligram once daily, 1 hour before or 2 hours after food, because food decreases the bioavailability, so it is taken empty stomach. Children above 6 months, the dose is 10 milligram per kg per day for 3 days is sufficient for most infections. Side effects are again gastric upset, abdominal pain, headache, dizziness. It does not interact with cytochrome 3A4, so no drug interactions are seen. So caution may be, but caution may be exercised. It has the post-antibiotic effect. Means even when the drug has been removed from the body, if we do not take the drug, its effect remains in the body of the bacteriostatic nature. Spiramycin resembles erythromycin in spectrum of activity and other properties. And it is effective against toxoplasmosis, and recurrent absorption in pregnant women is seen. It is effective in recurrent abortion in pregnant women, and limit risk of transplacental transmission of Toxoplasma gondii infection. Its specific utility is for 3 weeks course of 3 million units 2 to 3 times a day are repeated after 2 weeks gap till delivery. Other indications are similar to erythromycin, for which 6 million units per day is given for 5 days. Skin effects, side effects are, it can cause gastric irritation, nausea, diarrhea, and rashes. Thank you. That's all for Macrolides. I hope you understood my video. And if you understood my video, kindly subscribe to my YouTube channel. That is Dr. Nitika's Pharmacology Discussion. Thank you. Be safe, be healthy, be happy, be blessed. Happy learning. Thank you.